So I'd like to thank everybody for coming. So we're going to start with a short talk, or not so short, because I want this to be interactive. So anybody who wants to ask questions, please interrupt me. I'm more than happy to discuss anything that is up there on a slide or anything else that you have questions about. Most of the talk is going to be focused on the face because we don't have time to talk about the body. But if you have any questions about breast augmentation, implants, anything that's new on the market, feel free to ask. So we're going to get started with the talk. Then I will do some live injections, just so people who have not experienced injections get an idea of what it's like. And then we can have question and answer, etc. Okay. I'd like to introduce my team. Jamie is my assistant. She's right back there. Some of you may have met her. David is our business manager. Liz, I'm introducing everybody while they're eating because they have no time. Liz is David's assistant and our assistant business manager. We have Sam, who's our nurse practitioner. She's cosmetics trained. We've got Connie, who's our skincare coordinator. We've got Diana, who's one of our estheticians. We've got Jean, who is our senior esthetician and star extraordinaire, and a lot of other people who couldn't be here tonight from the plastic surgery team. So the goal of tonight is really to talk about how you can maintain your unique beauty and what are the new things that have come on the market that help us to do so. So for those of you, although a lot of you know me, a little personal background. I grew up in Romania, then my parents and I moved to Ohio, and then I spent all my summers growing up in Paris. I went to Princeton for undergrad, spent a year doing neurosurgery research at Harvard. That's what convinced me I didn't want to go that route and stay. My initial pathway in plastic surgery, I went to UPENN for my MD and my PhD, my residency, and I've been there since 1999, so for a long time. And for my interests really are the prevention and treatment of aging, both clinically as well as scientifically. So clinically, I talk and I do face and body rejuvenation, and research-wise, I have a basic science lab as well as a clinical research program on the prevention and treatment of aging. And where do we do plastic surgery for those of you who are new to the program? Well, we are at the mothership, as I call it, downtown. And then this is my favorite part of the world because it's very private and really allows us to have it built as a private practice, although we're at many other entities such as Presbyterian Hospital, Pennsylvania Hospital, Cherry Hill. Where else are we for private practice type entities? All over the place. In Woodbury, we bought Princeton Hospital, Virtua. Forget it. Like, I don't even, that's why I leave these two up, because I can't keep up with all the changes. But these are our main two. So we have a minimum of 15 plastic surgeons who are aesthetic and reconstructive surgeons. I'm the one who focuses mostly on reconstructive surgery out of all. We have plastic surgery nurses, nursing practitioners, PAs, medical assistants. We've got a ton of employees, more than 35, probably over 50 now. We're at over 6 hospitals. So we're really a large multidisciplinary center, which gives us a lot of tools for all of these things. However, with respect to cosmetic procedures, we really want to have a goal to achieve a private practice approach and environment. And so in plastic surgery, we actually have not only cosmetic surgery, but our own skincare program. So at Penn, unlike in other institutions, we actually are the ones doing skincare and aesthetic skincare. We don't do so much medical skincare, but we are the ones who do it in place of dermatology. So we have 2 really great medical estheticians. We've got micropigmentation specialists who not only do our breast cancer, nipple areola tattooing, but they do brows, eye tattooing, lips, etc., scarring. And then we have a lot of skincare and cosmetic coordinators who are specifically trained in this aspect. So what is our philosophy here? I think it's unique in that We believe that to provide the best solution for a patient, we really have to have comprehensive knowledge and highly skilled technical ability, which is not always true in other practices. So I believe that we always have to understand all the components of a beautiful face and body, and that we have to understand the body from the inside out. So not only the psychological aspects of a patient, why are they coming to see you? Is it because they've had a recent trauma or a recent life event, they've gotten divorced or a family member has died, or they've come into some money because their grandfather has died? What is it that motivates them to get to this point? But you also have to understand their bony structure, their soft tissues, and their skin. So all of that together. And that has to be true from the top down. So tonight, what I'm going to talk about is face and neck anatomy, ideal proportions, current tools and approaches, and what we have for the future. So what are the important principles of beauty? Some of us know it, not all of us appreciate it. Well, they're actually measurable quantities of beauty. And these are principles that I've tried to demonstrate across all genders, ethnicities, and cultures. So averageness. You don't want somebody who looks outside of the average. That's not considered beautiful. Sexual dimorphism. That means a feminine face should look more feminine. A masculine face should look more masculine. Youthfulness. Symmetry, but not perfect symmetry, because that's not natural and it doesn't look normal. Elements of childlike features. Large, full forehead. Rounded, smaller face. These are the types for women that are considered measures of beauty, as you can see all across. And if you pull up pictures all across the internet, you'll see the same concept. This happens to be my daughter, so I'm a little bit biased, but I can't resist her because she's so cute. And she doesn't look like me when I was a baby. So. What are the fundamental features of the beautiful and youthful face? Again, these translate across all ethnicities and cultures. Smooth, glowing, firm skin. Can't argue with that. No temporal hollowing. This area that gets hollowed out over time. We call it the peanut head deformity or the PhD. You want a laterally arching brow. You can't see it here, but it should go like this. In a male, it should be more straight. So you have to recognize what's attractive in a male versus a female, because that's where that sexual dimorphism comes in. A short, smooth lower lid. Here's that lower lid. In a youthful patient, you don't see that transition here. And that's the goal, and that's what happens with aging. You start to see this transition for whatever purpose, because you get more hollow, because you get more full. So you want that transition to be smooth. And you want a pleasing ogee curve. That's what this is, that little nice curve. It's an S curve. That's what the goal is, especially in a woman, not necessarily in a man. And you want a subtle nasolabial fold. You don't want it to be a face because that makes you look like a monkey. You don't want to be flat. So people come in and say, I only want this, get rid of it. I say, no, because that's not natural. So stop focusing on that and let's focus on everything else. You want a well-defined mandibular border because this area gets effaced with aging, and you want an angle that's relatively sharp here because that also gets more effaced with aging. So our goals really are to optimize, prevent, and restore. And I call it the aging tug of war. Why? Because when we're youthful, the upper part of our face wins. We've got really strong features in the upper part. This area is an upside down triangle, so it's a more pleasing curve. As we age, the lower part of our face gets stronger and wider. So you always see these downturn angles, those lines of bitterness, these jowls, etc. So this is what we want to improve. And so what kind of tools do we have at our disposal? Well, I call this the lifelong aesthetic aging pyramid. So at the bottom are these lifestyle aids. Everybody can do it: skincare, exercise, nutrition, sun protection, etc. Then you go up to your next level invasiveness: peels, laser resurfacing, injectables, etc. And then you get to your most invasive, which are surgery. once you have your surgical procedure, you're not done. You have to actually maintain those results. If you stop here, those results are going to be very temporary because we don't stop the clock, we just reset it. So you really have to maintain all of these lifestyle improvements. So when a patient comes into our practice, whether it's into my office, Jean's office, Deanna's office, what we look at is where are you in the treatment pathway? Are you a candidate for skincare and prevention? Are you a candidate for injectables? Or are you a candidate for surgery? Almost everybody's a candidate for skincare and prevention because you have to take care of your skin. But we look at it from least invasive to most invasive and really determine where you are. And I would argue that for pretty much everybody, when you look at a face, the first thing you see is the quality of the skin. So smooth, glowing, firm skin. And so that's one of the first discussions I have with my patients. And I'm lucky enough to have our great estheticians with us who support us. And we actually, for those of you who are not familiar with our practice, we work very much in conjunction with one another. So a patient may come to me for a surgical procedure or cosmetic procedure. I send them back to Jean just to get their skincare in order and vice versa. So we're very interdisciplinary and we work in a very collaborative fashion. So what we both believe is that the optimal skin requires kind of 4 different categories. You need your home regimen. You do this twice a day, morning and night. Then you need your office rejuvenation, whether it's a skin peel, a resurfacing in this dermaplaning, silk peel, whatever it may be. You also have the option of doing a home rejuvenation in the form of a home peel, where you have a slightly higher acid load, but you're still exfoliating between these 2 appointments. And then you have your resurfacing. So if you want to have a higher dose laser, etc., you can do that every 3 to 6 months or twice a year, etc. This is the take-home page for the skin hair home regimen. Daytime, you have to protect your skin, okay? So you cleanse it, you exfoliate it. I do these in the shower. Antioxidants, growth factors, peptides, these kinds of products are constantly changing, so we always have new products. We'll give you or recommend to you whatever is the newest and best. Then you moisturize. If these are not sufficiently moisturizing, then you put a moisturizer on top, and sunblock always have to be applied every 2 hours, whether it's mineral-based, chemical-based, etc. So if you put on your sun protection in the morning, when you put on your makeup and you're out of the house 2 hours later, it's gone. That protection is gone. It only lasts 2 hours, so you have to continuously maintain it. Not very easy to do with a cream. That's why we have powder-based sunscreens, and that's why those have become very popular with our women, men, kids, all of those populations. So those are the things you have to think about. At nighttime is your time to be more aggressive and to repair the damage that's done. So cleanse can be the same cleanser, doesn't matter. That's when you want to use your retinol, retin A, really strong agents. And again, you can use your antioxidants, growth factors, peptides to protect, moisturize, put a really thick moisturizer, let it sink in and really take care of your skin. If you're prone to breakouts, obviously you're not somebody who wants to put that on. Tonight we have some different recommendations from Jean and her team with Skin Medica, which is really probably the most scientifically based skincare line that we carry, but we carry pretty much all the top skincare lines that are medically graded. And as probably some of you know, we change our recommendations all the time because skincare products change all the time. So we want to make sure that you are all on the newest and best products. Any questions about skincare or our practice? Because I'm going to switch into presentation and evaluation for injectables. No? Okay. Do you guys want to take a seat or are you okay standing up? You're good? Okay. So what happens when we have somebody come into our office? we already talked about skincare, but for my purposes, I don't tend to see patients just for skincare. They come to me for more severe changes. So I ask them to bring in a picture of what they look like beforehand, ideally. They don't always do it on the first visit, but I try to do it at least on the second visit. Then we assess the areas that are of concern and that have sustained damage anteriorly and laterally. And then my job as a surgeon and as a physician is really to assess all of that in the context of vasculature, which is very important, musculature, which is secondarily important, the fat compartments of the face where we put fillers, and then the bony structure. All of these compartments, from the top to the deepest, from the most superficial to the deepest, change with age. And they change differentially in different people. So certain patients may have more bony changes if they're really osteopenic. Other patients may have a lot more skin changes. So you really have to assess the tissues in the context of the patient. And so you have a patient, for example, such as this one. You have to superimpose her anatomy and really assess them in that way, so that when they come in, you assess what are the critical areas that are the danger zones of the face, and how can you inject them in a very safe way. And I show this picture only because a lot of patients and injectors consider that injectables are safe, they're minimally invasive, so it's not a big deal. It is a big deal. These are all the critical structures of the face on a real patient. So if you inject in the wrong place and you inject intra-arterially, your risk can be blindness. And so you don't want to get to that place. You can also inject the parotid gland, etc. So these are not trivial things, and you really need somebody who's a good injector. I'm not saying it has to be a plastic surgeon, but it has to be somebody who understands all the different levels and all the different anatomical compartments of the face. So you need depth and synergy. So what can injectables, and most of the talk will be on injectables, what can we reliably achieve with this? Well, we can prevent and treat motion-related wrinkles. That's typically neuromodulation or neurotoxins or Botox, Dysport, whatever you want to call it. But what can you do to correct wrinkles, restore volume and shape, sculpt and change the facial shape, postpone surgery, maintain surgical results? Well, that typically requires a combination of neurotoxins, neuromodulation, fillers, and or Kybella, which is a lipolytic agent that dissolves the fat in the chin area and other parts of the face, which we'll talk about. So really the goals are to optimize, prevent, and restore. So optimize the facial shape in younger patients who may have a deficit. Let's say you have really flat cheeks or a really small chin and you're young. Well, you can optimize that with facial fillers or other agents. But when you're in this age of 30 to 50, this is when you really want to maintain facial aesthetics and prevent aging. So you want to maintain what you have and prevent or delay aging. So you want a really natural approach, little by little, less is more, and not to change the look of your face unless that is the goal. And finally, when you're in that later section, you want to restore facial aesthetics and maintain any surgical results that you may have had. So what kind of tools do we have right now? Well, as most of you know, we have 3 in this country. Other places they have more. We have 3 FDA approved neuromodulators. There's Botox, there's Dysport, and there's Regimen. And we have all of them. They have different properties. And the only thing you need to know is really they're not interchangeable. They're all effective, but they have different applications. So if somebody says, oh, I need Botox, well, yeah, Botox was the first on the market, but there are different indications for all of them. So it's not wrong to use one versus the other, and patients have different preferences, physicians have different preferences. We use them all because I think they have really different behaviors in different patients. Well, what about fillers? This is an old table from a paper I wrote May of last year. These were the hyaluronic acids and the calcium hydroxyapatite, which is the Radiesse fillers that were approved in this country. So as busy as this looks, in Europe and everywhere else in the world, they have 160 plus fillers available. So imagine the confusion of somebody selecting a filler. We think we have a lot, but it's nothing compared to the rest of the world, which I think is actually good because there are some differences between them, but they're not significant enough to really warrant that huge number of fillers. So forget that. FDA Approved Biostimulators. So they're fillers, which are typically hyaluronic acid or Radiesse, which is calcium hydroxyapatite. And then there are biostimulators, which means you inject it and it stimulates a collagen formation. So it's not that it's a direct effect of the filler. There's Sculptra, which is PLLA. That is a dissolvable inflammatory agent, which is very good, but it's not an immediate effect. And it's temporary. Bellafill is another agent which has PMMA microspheres. You may have known it as Articol or Artifil in the past. It didn't get a very good reputation in part because the PMMA microspheres, which are little plastic beads, one, they're permanent, and number two, when they initially made that filler, they were not very well processed, so the size was not very consistent and they were not very small. Now the company has optimized their approach, and so I think their results are much better, but they're having a hard time getting back on the market because of all the negative publicity. So I'm on the fence. I'm willing to give them a try because they have some really nice data, but I think they have to overcome some of the negative things that they went through. Kybella. How many people have heard of Kybella? Large number. So Kybella went through a really aggressive DTR, DTC, direct-to-consumer advertising. So this is an agent that is directed for submental or under the chin fat. And it's actually deoxycholic acid, which is a bile acid. So it's from your gallbladder. It's natural. It breaks up the fat cells. So it causes an inflammatory reaction. You get to have a little bit of swelling. I call it the pelican neck. But then once that's absorbed, the fat cells are gone. So it's actually a permanent effect, but it needs to be done in a series of treatments. And I'll talk later about the fact that now we use it other places. So presentation and evaluation. Patient comes to me. She's got a lot of volume loss, a lot of other things going on, but my job as a physician is to look at her in an anatomical way, very static with all the anatomical areas. So I can make an injectable plan. This is an older slide. There are other options here, but the point is to show that for all of these areas, you have different options. And so if you're a good injector, you can use different products in different areas to achieve really good results. Same thing on the side. So you can be very meticulous and very conservative at the same time. So this is actually a mirror image. This is the same, this side of the face is this treated side. So you can see a little bit of fullness. This is corrected. Botox, obviously you can't see immediate because this is an immediate post-op picture. This area, a softening of all of these lines around here, a softening of this mental sulcus, but very natural. So this is the goal, at least at the first visit. You want to be really soft, really natural, and nobody's going to know, and that's actually the goal. As long as you know, it doesn't matter if anybody else knows. So in my practice, I really like to focus on areas where I can achieve an excellent result in contrast to surgical intervention, because I'm a surgeon, so that's my baseline. But if I can use fillers or these injectables to really achieve a nice natural result, why not? Keeps you out of the OR. It's fast, it's in and out, and it's safe. So there are certain areas that I like to treat. So for example, you have a gummy smile like this. Well, a craniofacial surgeon might say, okay, well, you need to bring up the maxilla, break up the bones, pull it up. Well, yeah, you can do that and you'll have a permanent result, or you can do a baby dose of Botox and have the same thing. So it's a trade-off. I'm not saying one is right or wrong, but it's really a trade-off. Here is a patient who has these downturned lines. Who doesn't know or doesn't feel like they look like that with advancing age? This is just that tug of war where the bottom part of your face wins out. You got these lines. One of our best known facial facelift surgeons calls them the lines of bitterness. And as much as I love him and I hate the term, it just sticks. So it's very easy to reproduce. You do a little Botox. Here, you prevent that. So it's really nice. What he does is actually in his facelifts, he transects these muscles. He cuts them. Most of us are not so aggressive because all the nerves are coming this way. So we don't even want to go to that area. But this is just with a little Botox. Okay, temples. One of the most underrated areas. This is a patient of mine. Look at these areas that are hollowed in here and hollowed in there. What happens in the lateral edge, posterior aspect of the brow, gets sunken in. You don't see it anymore. And so when you restore it, you can actually see it. We call this the peanut head deformity, as I said before. It gets sunken in. A lot of times this happens, can happen natural, but a lot of times it happens in patients who have bruxism or really tight clasping of the jaws, and you can feel the masseters. Patients who have migraines from grinding their teeth. Why? Because the fat pad that feeds this area is contiguous to the fat pad that's right next to the masseters, which is right here. So you give a baby dose of Botox here to soften it up. Okay, you may not be able to chew an apple or the hard steak, but that's not the worst thing in the world. And then you'll maintain this. You do a little filler there. But if you see that hollowing, it's characteristic for really the grinding of the jaw. And if you look at the side, you can see the difference. And this type of venous congestion is normal. It goes away in about a day. Okay, tear troughs, one of my favorite indications. Patients with really good skin have a little bit of hollowing there. They look tired. There's nothing better than doing a little injectable. This is 2 minutes after the injection. She's very lucky she didn't bruise. It's not always so good, but it's very, very easy to correct that as long as you have good tissues. If you've got a lot of extra skin and your muscle tone is not so good, it's not a good time to do it because you're gonna swell a lot. So you're better off tightening the skin and the muscle before doing a filler. But this is very easy to do. Here's another patient, happened to be the mom of a resident of mine. Had some temporal hollowing, some lateral brow drop. This is the pre and the post. This is the mirror image. It's not two sides of the face. She had some hollowing here. So here she is after a little bit of filler here. Just a very soft look. And also here, because she had this hollowing that's not very normal, we call it the A-line deformity. A lot of people think that if you hollow all this out, it makes you look younger. It actually makes you look older because it gives you a skeletonized look. So you actually want to have that fullness there. What you don't want to have is so much fullness that it falls down. Filler. Filler. She only had filler. So filler here. Filler here. See how this is sunken in? And then filler here. Just a little bit. Baby doses make a big difference. Another patient. Okay? All these lines. Male patient, you don't want to overdo it because you don't want to give them the Kenny Rogers look. Again, this area. He didn't want to go to the OR. Botox, almost overdone. Currently, I wouldn't do it so strongly, but trim, filler. Very simple in office. So you got to use all your tools all together. This was, let's see, 7, almost 8 years ago that I did this. This happens to be my dad.
That's great.
So anyway, they happen to be the best tools, but they usually also have the worst complications, but not in this case. You know, it's family members or people you know, but anyway, he looks phenomenal. All right, nasal contour. What people don't know is that you can use fillers for cosmetic rhinoplasty. And I should have put some other slides in there, but I didn't have time. So for example, for post-rhinoplasty contour deformity, where she's caved in here, you put a little filler here, you smooth her out. Same thing with the contour of the dorsum. You have a dorsum that has a little bit of a hump, you restore here, and here you smooth it out. And it's very, very simple. This area doesn't have a lot of motion, so it lasts 7 months, a year or more. Very, very good correction. Lips. Everybody's talking about lips. You don't have to make people look strange. Not duck lips, not strange. In fact, what we're learning is that to build a really nice, there are two things. One, you have to know whether the lip contour is a nice lip contour. Then it's a very easy augmentation. If you're trying to change the lip shape or the contour, then it's a much more complicated procedure that typically requires multiple steps. This girl is beautiful. She has pretty lips, but she also has very strong features around her. So she felt that the lips were a little bit too thin, but wanted to maintain her lips shape, which I agreed with. And so we just did a baby dose just to augment it so she looked a little bit more feminine. This patient, again, home run. She had beautiful lips. Here she is before, here she is after. Baby dose, you can see because she still has the blood on her, so you know it's immediately thereafter. Baby dose, just really to soften it up, give her a more pillowy effect. And so it's not, I don't like to change the lip contour if I don't have to, because I think that gives sometimes an abnormal shape unless we build it up slowly. If you're willing to build it up slowly, then I'm willing to do it. Otherwise, just give a little fullness. What we can also do is restore perioral asymmetry. So, for example, she had an iatrogenic injury to her lip. This is pulled down. This is a little bit more fill. So we treat this area to try to restore it and give her a little bit more symmetry. So it's not just for augmentation. We can do this for all sorts of things. And this was, you know, some patients are born with this. No sides of this face are perfectly symmetric. Jawline. Here's a patient of mine who is very pretty, but she never had a jawline. Here she is, it goes up like that. A little bit of jowling. So I said, forget your nasolabial folds. Those are not important. Treat the jawline. It'll give you a stronger, more youthful profile. So we treated the jawline here and anterior to here. That way you strengthen this and strengthen this. We could have done a lot more to be more aggressive. But when you look at it, it actually gives her a stronger and better jawline than when she was a student. And so those are the kinds of things you can use to optimize the face in a very subtle way that nobody will ever know. You'll know, and it'll make you better over time. Submental and superficial neck. We talked a little bit about Kybella. Very subtle results. So it's for somebody who's either not a medical candidate for a neck lift, doesn't have access, can't recover, doesn't want the scarring, doesn't want to deal with the cost. This patient, he was one of my nicest patients and still is. He came and had 6 treatments. He went from here to here. He is not a surgical candidate. He was on a transplant list for his heart, so very complicated, but he was happy with this change. He said, it changed my life. I said, okay, it's your choice. But for me, this is not a significant enough change after all that time. But for him it is. And so you really have to incorporate the patient's wishes and what their goals are, because you don't want to say no if their life situation only allows them to do certain things. So as long as you're not hurting them and you can actually improve a little bit of their life quality, then I think it's okay to consider that. So we got to think outside of the box. Here's one of my favorite patients. Came to me having tried a gazillion things. She had lipoatrophy secondary to dermatomyositis, was seen by multiple partners of mine with no effect. These are after fillers. She failed fat grafting, other fillers, etc. So I worked up a program with her, and here I said, we got to do a little bit at a time. Like I tell all my patients, come back every month, we'll do a little bit more. And so we did serial injections every month until we got her to her goal. And then she was finally able to maintain this, and now I think she comes back, every 3 months or so? And she was never able to do this before because she's got this autoimmune disease that doesn't allow her to maintain any fat or any filler. So you got to think outside of the box, and as much as I really think this is all cosmetic and has no value, all the things that we do have a lot of psychological and physical value. So each patient is unique. Each treatment should really be uniquely tailored to the patient, and no single treatment is appropriate for all patients. So we have all the injectables, we get the new things all the time, and that's why you need to really do your homework and make sure you know who you're going to and that they have a good approach. Here's a patient who's 45, here's a patient who's 42. Are you going to treat them the same way? Absolutely not. So what's new? Very much excited about a few different things. Volbella and velour. A lot of you know about Volbella. So Voluma. So all the companies have changed their naming. So they've basically tried to put all the names under a similar umbrella, which makes it very confusing. So I don't blame you for getting confused. There's Voluma, which was the initial long-term product. Now there's Volbella and there's velour. And the reason they all are called the same thing is because they're all subject to the same technology of cross-linking the hyaluronic acid, which makes it last longer. So the beauty of these products is that they last a lot longer than a lot of other products, or at least we think so, because they've extended their studies to that point. Now, the most exciting part is that while these are great in the sense that they have longer or enhanced longevity, we have a new series of products from Galderma which have a completely different technology of performing or producing these hyaluronic acids, which are in Europe and everywhere else in the world known as OBT, or optimal balance technology. Here they're called expression. And so the point of these, the difference between them is that they're more natural, but they maintain the motion, and I'll show you why. And then Kybella, that dissolution agent for the submental area, we're expecting additional indications to be approved soon. So certainly I'm doing a lot of jowls, a lot of little axillary areas, etc. You don't want to go to large areas because budget-wise it's not worth it. You're better off. But this is what I think about. How long will it last? Patients, you're on a budget. I respect that. So let's focus on budget. So Velour, Voluma, Juvederm typically lasted a year. Now we're talking about 18 months or more. So now we have a whole armamentarium of different painting products. So Volbella is the thinnest, then we've got Velour, then we've got Voluma, and we'll get some things in between. So from a long-lasting standpoint, we've got this family of products. They're very similar to what we had on the market before, except for the time frame. So patients always ask me, how do you decide? Or I just want Juvederm, or I want this. Well, no, because each product is completely different from the other. So if you have an injector who's very well educated, every product has a different property. So that's why I carry everything here, because it's important for me to be able to treat each kind of patient. So you think about elasticity and you think about viscosity. So this is an easy way to think about it. You have Jello, right? This has high elasticity and viscosity. So when you push on it, it bounces back. So it lifts the tissues more. It's more resistant. It's more stable, as opposed to pudding. Push on it, mushy, but it's more smooth. So these are just two of the characteristics that were previously used to define these fillers. And while it's very difficult to explain to patients, this is how I think about it. And imagine that you have very thick, firm skin. If you put this under your skin, you're not going to have any result. If you put this under somebody's skin who's really thin and really atrophic, you're going to have lumps and bumps. So you have to really assess the quality of the products in relation to the patient's tissues. And if you can't do that, then you're going to get problems and not an ideal result. So this is why it's so exciting to have these products. And that's because they have a whole new performance and variable, and that is they have elasticity. So instead of the other products, and I'll show you, these are actually, so the ones that you have, the Jello and the pudding, these are nothing like that. These are like sticky putty. So you push on them, they stick with you. They're much more like your natural tissues. So they have kind of a fourth dimension of mobility. And the Refine here has more mobility. I think it has the fishnet that has larger holes, and this one has a little bit less mobility. But if you look at them, so this is the Restylane family, Restylane L, the lift, which some of you have seen as the highest G prime, which gives you the biggest lift and is the stiffest. So look at how stiff that is. Doesn't move. The silk that we use for the lips, these are, and this is the same amount of product being injected for all of these. This is how much it stretches and it bounces back. So really what we're talking about is the fourth dimension in facial dynamics. So we really want a natural look, and now we don't look at static images anymore. We look at how you talk, how you smile, and how we want to optimize that rejuvenation. So why do we want to do it? Because most of us really respect our facial expressions and our emotional language. And I would say the number one complaint or resistance to fillers is looking stiff and unnatural, even more so than toxins. And so when you can get away with that and really assess patients in neutral, big smile, different areas of emotion, you can get a very natural expression profile. So here she is, she had, and you can look at the motion, it's very, very natural. And you remember, you don't want to efface those nasolabial folds. That makes you look like a monkey. We call it the simian expression. You want a softening. That's all you want. And you want a softening of this area. Very, very natural. So when you come to my office and I ask you to make all these funny expressions, you'll know why. I always did that anyway, but I was the founder of this study, so they actually recognize the importance of all of these. So when you have somebody who looks really overdone and they can't smile, that's when you notice that they've had something done, because they can't use their face, and that's strange. So that's why the fourth dimension of motion is the most important. So here's a patient relaxed. Easy to get this result because everybody looks good when you've just had that. But do they always look good when they move? Look at the nice improvement in this area just with a little filler there. So, future. We're always going to have lots of new products, lots of new technologies. But our goals as physicians is really to, and for you, is to educate ourselves on their safe use, the appropriateness, and the ideal indications. And long term, and I didn't talk so much about surgery, but we can, is when do we combine surgical applications with really these injectable applications? Because if there's some point where it becomes self-defeating to just do fillers. One, from a financial standpoint, and two, from a natural look standpoint. You don't want to look overdone. And so that's our job to recommend to you, and then we have to know when to say when. And so our goal is really to improve, maintain, and restore your look and the goal that you'd like naturally. I'm happy to answer any questions, and I thank you for your attention.